Welcome to the Phoenix Prosperity Podcast, where wealth meets legacy. Join your host, Tim Fergestad, as we explore the journeys of Phoenix's finest to success and beyond.
Hello, this is Tim Fergestad. Thank you for joining us. I'm very pleased to have Dr. Mustafa Al-Ogaili with me here today, or Dr. O. He's a diehard interventional radiologist at the IM Medical Group and founder of Amaji. So very excited to have you on the show. Welcome.
Hi, thank you. Thank you so much for having me. This is an honor and a pleasure. Thank you so much for allowing me the time. It's what you have right here is amazing. It's actually marvelous and also inspiring. When I heard first about the invitation on the podcast, I was like, I'm so excited. I was counting the days.
Oh, thank you
so much for allowing me the time.
Thank you. That's awesome. That's awesome. I'm super excited. I was telling you before we started the show that interventional radiology is probably what, if I would have gone into medicine, that's what really floats my boat and I would have loved to have gotten into. And it's just a booming industry. Do you want to just dive right into that, the specialty?
Yeah, it's actually, I do believe that it is the future. Minimally invasive endovascular procedure and image-guided procedures in general, and not just interventional radiology specifically. There's a lot of specialty that utilize and leverage those advantages, for example, of doing an image-guided procedure. So interventional radiology is right now it's becoming its own specialty, its own residency. Back in the days, I'd say not even more than 5 years ago, it used to be a subspecialty, a fellowship out of the residency of radiology. Right. Even though the specialty has been here since the 1950s, Charles Dotter is the one who started the specialty. The first procedure being treating minimally invasively endovascular procedure to treat the arteries that are closed in diabetic patients. The video is still there. If you go on Cook Medical, for example, on the website, look Charles Dotter, you'll see the video. He's shooting it with his old camera, very slow, and black and white.
Sweet.
Yeah. Like you can watch the patient he selected from the streets. He's limping and he had foot pain, and he decided that he has arterial disease. And he went in with a catheter and showed you the blockages in the narrow area in the arteries, and he opened it. And that's how we started the specialty in 1964. Oh, wow. They published the first transluminal endovascular angiography with treatment of that vessel. The paper is still there from 1964, and that's how the specialty started. And
excellent.
We've evolved so much since then. We do a lot of stuff in this specialty right now. We leverage all kind of imaging modalities, from MRI and PET CTs to CTs to ultrasounds to fluoro and X-ray and all that amazing technology that we have nowadays.
Right. It's interesting how some of those technologies as they advance get sort of ingrained into other specialties, right? They adopt them and make them kind of their own in a sense, I suppose.
Right. Yeah. This is just the examples are many. Starting with endovascular stuff, vascular surgery now do the peripheral arterial disease, which is the procedure upon which the specialty started. So that's vascular surgery now. Colonoscopies and endoscopies, they used to be interventional radiology procedures. The specialty came up with them, and now gastroenterologists and advanced endoscopists do them. Other procedures like interventional pulmonologists, they do the biopsies through bronchoscopies. That was an interventional radiology procedure. And the examples are many. Biopsies and bone marrow biopsies and stuff. They're done with interventional radiology as well. And now we have this procedure, this novel, well, it's not technically novel, it's been there since the 90s. It's called prostate artery embolization, for example, where we go and we try to shrink your prostate from its enlarged size to a smaller, more tolerable, to relieve the lower urinary tract symptoms that most men over 60 suffer from. 80% of men get benign prostate hyperplasia around that age, in which the prostate just enlarges, and the standard of treatment has always been, oh, you go to a surgeon, you go to a urologist, and they cut it up. Now, we developed this procedure called prostate artery embolization, where we block the vessel, and it just shrinks down and relieves the symptoms, and it takes half an hour to 1 hour, and you recover in 1 hour, and you walk home. Minimally invasive, no scar, no surgery. The complication rate is very, very low to negligible. And patients find relief and they enjoy it. And nowadays, even urologists are starting to take initiative to do these procedures. So the specialty keeps giving, because I do believe, like we said, it's the future of medicine. It's going to keep evolving. And the more it evolves, the more other specialties will take from it.
Right. It's kind of the pioneering specialty of medicine,
Yeah.
and I guess it's a little bit complicated in the sense that as its own specialty, as you can't know and do everything, right? You kind of sort of have to start giving these things off to other people, or no? Do you want to be able to just do everything and treat every tissue and every organ, and right? Do you know what I'm saying? Is there a limit to how much you can include in that in interventional radiology?
Right. So the limit to discovery doesn't exist. The sky's the limit. You want to go as far as you can. You want to learn.
Sure, but in terms of practice, training in your clinic,
practice is different because that's always been the bottleneck of any science, not just healthcare, not just medicine. The bottleneck of any science is the human bandwidth. There's only so much you can learn in a given amount of time, and there's only so much you can do in a given amount of time. So we're actually the bottleneck. So you want to actually spread it. And I think it's extremely inefficient to just have one person or one specialty or one thing does everything. That's just not just inefficient. It's also like you're not doing the patients a favor, because there's so many people that need help. And if you keep just having that knowledge just for yourself and to you, that's just you're not doing your patients a favor by that. You want other specialties to help the patients in ways that you discover, and that's how science evolves. That's how it's always been done. Now, that being said, having the territorial mentality has never helped any science or any specialty, not even in politics. It doesn't work. It only creates problems, and that's not obviously in the best interest of the patient. So yeah, is it doable? It is doable to have someone, a specialty who does everything, but then that will obviously hinder the progress of the person, specialty, or even the institution. So yeah, you want to spread the knowledge.
You can be a jack of all trades, but a master of none, right? You want to give the procedure the attention and focus it needs. So I don't want to get into the U.S. slow adoption issues of new technologies and medicines and stuff per se, but back to the specialty technique designations, colonoscopy, for example. Are interventional radiologists in most settings practicing colonoscopies, or is it truly just GI specialty procedure for insurance purposes, for example, now approval?
That's a great sentence. For insurance purposes. So actually, I would be extremely surprised. I would be like, it would be something that we have to write a case report on if we find an interventional radiologist that does a colonoscopy today. So that's how things like turned at this point. So when you go, for example, if you want to do colonoscopies, you go to internal medicine residency, then you do 3 years of gastroenterology fellowship, then you go to advanced endoscopy, which is 1 to 2 years depending on the institution. So that's 8 years of training. And then after 8 years of training, you want to be like, okay, so this is what I do. This is what I'm good at. You're not going to have someone else, because this is your style. Like, you narrow it down to become an expert of this, and you are an expert of this because you've had all this training and education. So I would actually be surprised. But on the other hand, for example, endovascular procedures like arterial diseases and prostate artery embolization, those are procedures that are shared at this point across multiple specialties, with the arterial being shared with, for example, vascular surgeons. The neurology, anything above the neck, carotid, and the brain is shared with neurologists. Neurologists have their own fellowship in interventional neurology. They fix strokes and bleeds in the brain, and AV malformations, congenital malformations, and they're evolving so fast we can't keep up with them. So they have their own fellowship right now, and that's a different residency. And like the other example, for example, would be urology. Now they're thriving to do, and even OB-GYNs. We've had obstetric gynecologists here trying to find a way to have their own path towards another procedure that we've been doing since the 80s that insurance doesn't like, called urinary embolization. So we go in when we block the flow to the fibroid, for example, or to the lesion, or to an AV malformation where the vein meets the artery in an incorrect or abnormal way, and it fixes the problem. It's actually the only intervention that preserves fertility. That we have for fibroids, for example. Now OB-GYNs wants to do it as well. So there are things that are shared across specialties, and yes, insurance has a say in that, obviously, but also it's not just that, it's also like because the patient population and you don't have as many interventional radiologists. So, for example, in all areas,
Right.
it's extremely rare to find an interventional radiologist in rural United States. And even if you find them, you don't have the equipment probably, or the support staff. Those are not easy to get. So yeah, that's why they're shared across specialties. And on the other hand, there are things that only interventional radiology do. As for why, I'm sure they're not as, for example, exciting for other specialties. They require more training. I haven't done my residency or fellowship yet, but over the past 3 years, from what I've seen, there's something unique to a radiologist. I don't know how to explain it in plain and simple words. Anyone can look at an image and try to interpret it. You can just have them memorize it. But the difference is, from what I've observed, a radiologist, an experienced radiologist, can look at a 2D flat image and can think of it in 3D, in a volume 3D in their mind. So when they intervene with a needle, they can know exactly how deep and what the shape of the structure is. That's something I think you're either born with or not. Maybe some people get trained to do it with a lot of perseverance, but I didn't see that in other specialties. So that's why interventional radiologists perform better than other interventionalists, for example, from other specialties. That's why, for example, they do the biopsies. The biopsies, you won't find other specialties that do biopsies like interventional radiology. Some spatial skill or imagining skill that interventional radiologists and diagnostic radiologists have, because they go through all that specific training and they develop this character and they're rewiring their brain in that way. So that makes them unique to that specific, let's call it a brand or procedure type.
Okay. That sort of stereospatial training and all that. But just step back for a minute. I think for me, it's easier to think of because colonoscopies have been around a long time, right? And so that specialty was approved by somebody at some point to be done by the GI specialty, but an interventional radiology is not approved for insurance purposes, right?
Well, that's actually one way to look at it. That is, so here's the thing in the United States,
as the technologies keep coming up in different issues, in different things, they're going to keep getting specialized and brought into a different area, and then
there you go.
The standard of care will be okay.
Yeah, that's exactly how it happens. If you're a fully licensed physician in the United States, it doesn't matter if you do dermatology or you do, I don't know, neurosurgery. You're legally, one way or another, technically allowed to do whatever you want. But you have to have the training, right? You have to know how to do it. So just like, for example,
to get insurance reimbursement or to defend yourself in court if something goes bad.
Yeah, that's credential. Yeah, that's credential. So in a hospital, that's how they control what you can do as a physician, because even though the law protects it, it's different. In the hospital, they want to protect the hospital itself because someone can complain, oh, he's a dermatologist, why is he doing vascular surgery? It's not within his specialty. So they want to protect legally, they want to protect the hospital and the staff, obviously, and the insurance company as well, by saying, okay, this is your specialty, this is what you're going to do. So this is how it happens. And we have those endoscopists already. So like, okay, it sounds like they're the ones who should be doing it. So it's like, okay, yeah. And these areas, for example, the biliary tree where you have a gallbladder and stuff. Well, it's shared between GI and it's more vague at this point because interventional radiologists still go and put drains in the gallbladder and take care of stones in the gallbladder. And GI do the same. They do stents and stuff like that. So yeah, there are vague areas, but yeah, policies and hospitals, they control that, and private practice is completely different.
So let's talk a little bit about that then. So like the IA medical group it has a little bit more freedom to treat the patient and any issues the way they best see fit, and don't have as many restrictions. Is that a fair way of thinking about it?
Yeah, and the freedom doesn't come from the fact that we're going above the board. Like, for example, we're trespassing on other specialties. No, that's not the freedom we're talking about in here. The freedom is it's run by physicians. So when you run something by physician, a physician knows what they can and cannot do.
Right.
a policymaker is not always a healthcare provider in general, or a physician, not necessarily. And my understanding is that physicians are not even allowed to own hospitals in the United States. It's like, how is that even possible? So the freedom comes from, okay, the physician knows what they can do and what they can't. So they know that they have more liberty and freedom to provide the care that they can provide. And otherwise they wouldn't be able to do in a hospital. So, for example, right here, I've rotated in multiple healthcare systems in, for example, Texas and Missouri, and those places, their trainees graduate with 0 peripheral arterial disease cases. After 7 years of training, you haven't done one. It's not your specialty, it's vascular surgery. Even though you invented the procedure, you came up with, but yeah, you're not going to do it. And here, no, we do. We do 5 a week. We do 5 peripheral arterial diseases procedures, and we call them angiogram, with angioplasty and stent placement, and atherectomy when there's like a plaque and we take it out, or like there's a narrowing of the vessel, we stent it to make sure it's placed wide open. So that's something we do. Over the past 12 months, for example, and I haven't started my residency or fellowship yet, I was able to participate in over, I would say, 80 peripheral arterial disease in 1 year.
Wow.
Other examples, for example, procedures like genicular artery embolization. It's a procedure that is novel. It's completely new. It was actually discovered by accident. So when you do a total knee replacement to a knee joint that's painful or degenerative, or it's required or indicated a replacement, we notice that 5 to 15% of the population, after they do total knee replacement, the pain persists. Even though they have a totally new joint, but it's persists, right. It stayed there. So what ends up happening, sometimes they have a little bleed, or one of the arteries wasn't tight enough, or like they get new vascularization and that dumps blood into the joint space or the tissues, and we call it hyperperfusion with neovascularization, and that mimics inflammation, so the pain persists. So they sent them to an interventional radiologist. The interventional radiologist goes in, tiny little needle in the groin, and they go in, or the wrist, or the brachial artery in the arm, whatever they prefer, and they go in and they embolize that vessel that supplies inflammatory cells and abnormal blood flow, and the pain goes away. The patient wakes up and no pain in the knee. It's gone.
Wow.
So I was like, okay, is it the bleed or is it something else that's going on? Because we don't know. Is knee osteoarthritis a mechanical thing? Is the knee pain a chemical thing? Is it a cellular thing? We still are continuously changing our understanding of that. So we realized that this procedure can also help people who didn't do the procedure, right. The total knee replacement. So if you go in and you find one of the vessels that supply the knee is causing a problem, or causing what we call synovitis, for example, or inflammation in the knee joint in general, and you embolize that vessel, it doesn't destroy that vessel because it still has blood from other vessels, but it takes away the inflammation. Now, it doesn't reverse the joint to its normal state where you're like my age, for example. That never happens. But like at least it's pain-free.
Put a cap on the
progression of the disease. Right. Yeah, and it's something we offer. The success rate of genicular artery embolization combined with an ablation procedure where we treat the nerves as well is north of 70%. Some people get a 95% pain relief over 2 years. And it's minimally invasive. You can redo it as many times as you want. You don't get general sedation. You only need twilight for that. Sometimes most of our patients are actually on and off with twilight sedation. They're awake, they're talking to us, they're not feeling anything. And it takes half an hour. The recovery is another hour, and they walk home and it's done. And it's not like surgery to have those complications that come with surgery, such as, for example, bleeding, at least not as prevalent, or infection, or I would say like scar problems, or thrombosis, or fat embolism, or any of the complications that you can have with any orthopedic surgery or total knee replacement. You don't have that, or at least not to the same extent. So that's also something that we offer in here. Hospitals still don't do it. They only started to do it over the past year. We've had evidence and papers published about genicular artery embolization for, I'd say, 15 years right now. It's everywhere, literally. But they just started doing it right now. So you're governed by the hospital system, residency policies, stuff like that. Private practice, we offer that. We do at least 3 or 4 of these a day, every day. So I actually just got my logbook from the office because I'm required by the Arizona Medical Board to provide evidence that I've been reading and studying and performing, and I've been observed by a physician, a board certified physician, all that. So I just got my logbook for 12 months, and we've performed genicular artery embolization. We've performed more than 150 genicular artery embolization in 1 year.
2025. Okay.
Yeah.
Wow.
Yeah. So, and that's one thing.
Awesome.
Other stuff, like, for example, we do the same thing for the shoulder. Frozen shoulders and adhesive capsulitis. We don't have treatments for that. We just put them on ibuprofen, physiotherapy, take it easy and all that. And we'll hope for the best. Well, yeah, no, we don't do that. It's a tiny little needle stick in the arm. We go and embolize the inflamed tissue and the scar tissue, and the patient resumes normal physical activity in 1 to 3 months. They can abduct, and move the shoulder joint without pain or stiffness. It's marvelous. The data are there. The data is there. You can access it, and there's not that many offices that provide this. We actually, in this office in iMedical, we started the one of the very few, actually my understanding there's only 2 of them in the whole country, pelvic congestion syndrome clinics. So we have a special program for this pelvic congestion syndrome. Now, if you ask a layperson or even most of physicians, what is that? What is pelvic congestion syndrome? The most likely answer would be, we're going to try to come up with an answer, but we don't really know. We can't define it. You'd think it's rare. It's not rare. It's as common as asthma in the population. Can you believe that? Something nobody knows about. It's as common as asthma. It's as common as migraine. Like, this is, we have the
really?
whole program.
Pelvic congestion syndrome.
Yes.
Can you explain that, what that is to our listeners?
Yeah, absolutely. So, we started our own pelvic congestion syndrome program. It's a national program. And again, over the past 12 months, I know because I had to put it in my logbook. So we've done 660 pelvic congestion syndrome in 1 year.
Wow.
1 year. No one else does that. Like, just no one else. There's an office in Florida with Mayo Clinic. They do that as well. And they have a paper about it too. It's been very informative. I'm very grateful that they shared.
What are the symptoms? How does that present?
Yeah. So what ends up happening, your veins are supposed to drain the blood up, right? In your legs, you have valves and they prevent the reflux of blood. And then you have your muscles that pump the blood up. What ends up happening is you have some sort of narrowing, or like you bear down a lot, or pregnancy, or whatever it is that causes. What ends up happening is that you get.
We just, in America, we sit most of the day, all day.
I'm sure it's a reason. Okay. I don't have data to support it, but I'm sure it's one of the reasons. The mechanism works in my mind. I can work it up.
They accumulate fluid because the veins aren't bringing it up and clearing it.
Yeah, the blood accumulates in the pelvic veins, and that congest the pelvic areas. And the way that it impacts you get numbness in your legs, lower back pain, and women, which is most commonly, a lot of women have it. They get something we call premenstrual pain. So the pain is worse before their period, which is weird. Like, you have to have a pain on day 1 and decreases over the following day. Those women get severe pain before their period. Once it comes on the period happens, the pain just goes away. It just goes away. The other symptoms would be like pelvic pain, would be discomfort, heaviness, sense of heaviness. I've seen patients who have, because those veins are also connected somehow, which they're not supposed to be, to, for example, the colon, they get irritable bowel symptoms. So we go in and we close those veins. We close how old people get like varicose veins in their legs? Younger people get them inside their body, and we call that pelvic congestion syndrome. We go in and we close those veins and get immediate relief. 3 days later after the procedure, after we embolize those veins, they're like, okay, my GI symptoms are gone. My lower back pain is gone. I feel lighter. My heaviness in my thighs and legs are gone. My menstrual pain is better. And then if we look even further, we want to know what's causing it, because, okay, if it's something we can treat, then we should treat. And if it's something that's lifestyle related, we can make those adjustments to lifestyle. And we find that most of these people have something called May-Thurner, which is what's behind me. So a May-Thurner is a syndrome. It was discovered basically anatomically, your artery that supplies the pelvis area and the leg sits on top of the vein that drains the pelvis area and the leg. And the arteries are thicker, they're stronger, they have systolic blood pressure in them. So they end up with the pulse compressing that vein. And over decades and decades, that compression creates this reflux of blood into the pelvis and the leg and causing all these symptoms. So we go in and we find this compression and we balloon it wide open. We open that vein, and if it stays open, we send them home. We check on them every few months with ultrasound. And if it doesn't stay open, sometimes it's so severe, the balloon cannot keep the vein open. We have to put a stent inside it that takes care of the problem. And it's half-an-hour procedure. And how many offices are doing that? Probably a lot, but it's not a dedicated thing. Again, it's what fascinates me. I think it's hideous that a condition that's as common as migraines or asthma is not as popular, or at least known.
Right.
And I believe part of it is because it's a woman problem, not a man problem. So no one is really complaining because women are just, most of the time, unfortunately, they're just told this is the way it is. This
Well,
is not the way it should be.
it
Yeah.
sounds it may be kind of vague in this presentation too. They may not know, it's not like, oh,
Yeah.
my elbow hurts. It's not as clear cut.
Yeah. No, I
Okay.
agree.
Well, that's another good example of sharing the technology as things change. And you actually you founded Amaji. Can you to help do that, right? To
Yeah.
give back a little bit and connect physicians in other countries with the
Yeah.
technology and help this stuff grow. Can you share that a little more about that, please?
Yeah, and I when I graduated medical school in 2020 back home in University of Baghdad College of Medicine, I did my internship. I was required by the government to do an internship. It's part of your medical education and training. So we have a radiology department at the center, at the tertiary care center, trauma center that I worked in, and that radiology department didn't have an interventional radiology specialty. I had no idea what that is. It existed only, like, for example, in neighboring states or like in other centers. So when I started doing more reading and research, I realized, okay, this is this whole specialty. They do all these things, and nobody knows about it. And it's a whole country thing. So I started doing research. I got my research position here with Mayo, and I started doing my own with the help and support of the. Honestly, this is something I'm proud of. I've developed this network and connection of these people who've supported me endlessly. I wouldn't be here without them. The chair of the chair of interventional radiology here at Mayo, the program director of the APD, the associate program director, Dr. Al-Zubaidi, Dr. Patel, and Dr. Naiju, and all of the other faculties. We started doing the research, and I started involving other students from the United States, from other countries, participating in our papers, and started learning about it. It's like, okay, why are we doing it just for students? Why not just involve other board certified physicians or like radiologists? And it doesn't need to be research. We could just, okay, here, this is what we do. This is interventional radiology. This is what can be done. We have the infrastructure back home. We have CRMs, we have Flora machines, we have CTs and MRIs and everything. We just don't have people with the training. It's like, okay, you're a radiologist. You know how to read the image. You're trained how to read the image. This is the specialty. This is what we do. We started sharing information, started sharing clinical procedures, and we started sharing research papers and working on them together. And now, as of 2020, December 2023, we started the first interventional radiology fellowship in the medical city in Baghdad, which is the largest healthcare center, public healthcare center in the country. We have a 2-year fellowship for interventional radiology. It's something I'm proud of.
Nice.
I would like to think that I somehow opened the eye towards that specialty. And then also, we already have trained interventional radiologists back home. They work in multiple different cities in the country. So it has helped, and it keeps doing what we're doing. We have social. I encourage you actually to follow us on Instagram. We have this page on Instagram. It's Amaji Radiology. We post procedures every now and then, every week, whenever time allows, of what the things that can be done and the things we do in the office, and complications if they ever happen. Not that they would. Or wouldn't, it's something to teach the public as well, because people need to know about it as well. If physicians didn't know, it's not crazy to imagine that people didn't know about it. So, like, we want people to know that they have options and we can help them, and they don't. It doesn't have to be a hassle,
Sure. You don't want people working in a bubble, right? That sort of communication is incredibly important. It's effectively like a mastermind, right? In which everybody can share their information, their stories, and stay up to date.
Yeah, I mean, we have the internet. It's 2025,
right? Yeah, exactly. Yeah. That's all great stuff. What are sort of your big challenges or goals for 2026 in the coming couple of years?
Oh, that's a tough one. That's a great question. So I already applied for the residency. Through the National Residency Match Program, and I aspire at becoming, in one way or another, a proceduralist in a minimally invasive specialty. And there are multiple examples of this one. Interventional radiology is just one of them. You can be an interventional cardiologist, that's through cardiology and internal medicine, and there are other ways as well. So that's my aspiration. This is what I'm aiming at. Okay. So that's my number one goal. I want to be able to match in a residency program, hopefully in Arizona or anywhere else, or wherever they want me.
Is this the national program that comes out in
Yes.
the spring? You get matched in the spring? Okay.
Yeah, it's the National Residency Match Program. It starts every, I want to say June, and ends on February, and you know whether or not you matched and where you matched in late March, typically. So that's my first goal. And then I also just got married. So
congratulations.
Thank you so much. Yeah, so we're throwing our wedding hopefully February 1st. That's also on my a top priority for me. New life, you know. And then I thrive. This is what I like. This is what helps me get up in the morning. I like teaching. I enjoy teaching students and other staff members and other providers. So I'm trying as best as I can, to the best of my ability, to spread the knowledge about the specialty. I want more people to get introduced to what the specialty can provide, and because misdiagnosing or improperly diagnosing, or even diagnosing something partially, leads to overtreating, and overtreating can cause problems because treatment doesn't come without side effects or complications. For example, lucky ones are the ones who don't have side effects from medicine, for example, or surgeries that are not needed, and or like let's say they're overcomplicated for the issue. We can do something much less invasive and with the specialty, and that will obviously improve the outcomes. So that's another goal for me. Long term, I like having the freedom of doing what I think needs to be done. So private practice is also enticing to me.
Sure.
But at the same time, I enjoy teaching and I enjoy structure.
The academic settings are where some of the breakthroughs and the top cutting edge stuff's happening too. So it's
academics, because I enjoy teaching and I want to help improve and be on the frontier and the cutting edge of technologies. I want to be that as well. So I still am shaping and changing, jumping between one or the other, but we'll see.
Very exciting times. And I'd also mention, for our viewers and listeners who may not know, Match Day is when medical students and everybody, when they get to they don't know where they're going to go. They put it in a big program. They rate all the programs they want to go to, and the programs rate all the applicants. And on Match Day, everybody opens up their envelope and finds out where they're going to be living for the next year to 5 years of their life, right? And so your new bride will also be very excited on Match Day to find out where you guys are going to go.
I'm scared.
Yeah.
Yeah. We're hopeful. Yeah.
Okay. Very cool. All right. Well, Dr. O, if people would like to connect with you and learn more, where can they go? What should they do?
Oh, feel free to reach out to me. All my accounts are on social media. They're public. You can just message me, and I have I can throw my email as well. We can share it on the post or on the video as well.
Okay, excellent. I want to ask a sort of a reflection question to end up here. What do you wish you would have known sooner on your career path right now? What would have helped you immensely to have?
Two things. Compromise in politics.
Expand on that.
Sounds weird and irrelevant, but it's very important. It's extremely important for a physician to learn business. And I'm not talking about private practice business, but business in general, because business is politics and finances, and that's very important. If you want to build your life as a physician, whether you decide to go in hospitals and academic centers or you do private practice, you need to know how to leverage your contracts, leverage your business, and market yourself, and obviously in an appropriate way. That's very important, and that involves a lot of compromise. The second thing is politics. So there's my understanding from what I've observed, there's some severe distrust that is currently happening between the public and healthcare providers in general, but also doctors. And part of that is because most doctors haven't figured out at this point, a lot of them actually, how to play the politics. And politics are important because you're not dealing with textbook, you're not dealing with a standardized patient, you're not dealing with a mannequin, you're not dealing with a plastic, you're dealing with a human, and those humans have their own set of beliefs and politics in mind, and you have to be able to
sales.
Yes.
and communication. Yeah,
and it improves. We have evidence that says it improves patient outcomes if you can relate to them and connect with them on a deeper level. That will eventually improve your outcomes. So that is something I wish I've learned earlier. I'm still learning, and will always be learners in this regard. And medicine doesn't stop, so there's so much learning to do. But it's exciting. It's exciting to be living in these times with everything that's going on. It's so exciting.
All right. Excellent stuff. That was all. I enjoyed that very much. Thank you. Thank you, everybody, for listening and watching. Thank you very much, Dr. Al-Ogaili, for joining me today. Appreciate
Thank you so much
sharing.
for having me.
Yeah, I appreciate you sharing. All right. This is the week of Thanksgiving, so this won't air probably for a month or so, but thank you for that. Thank you for spending your time with me this week, and thank you everybody for listening. We look forward to having some great holidays coming up, and I look forward to reconnecting with you.
Pleasure. Thank you so much.
Inspired by our guests? Visit PhoenixProsperityPodcast.com/guest and join us on the show and share your success story with Tim. The spotlight awaits.